Thank you. Okay, so I'm trying to start from basics, involving you from very easy issue. So, what is sepsis? You can actually use your color cards trying to answer what is sepsis. Is it a complicated infection? Is it a piece of rotten meat? Is it a wrong reaction? Or we still don't know? So what do you think? A blue one? Blue, blue, blue? Great. Blue, blue. You go for blue. I'm not going for blue. There's no green, but you can use probably the purple one. Yeah, purple is green. If you want to choose green, you can use purple. Wait, purple. That's one purple. Okay. Well, actually, two purple. Two purple. Probably it's not so wrong saying that we still don't know. We still don't perfectly know what is sepsis. But I'm going to say a bit later that probably we should not consider sepsis as an infection. That's it. So, second question. What do you think is the first in-hospital cause of that? Is it the acute infarction, acute cerebrovascular event, a lung tumor, or sepsis? Again? A purple, purple, yellow. Wow. Yellow. Okay. Well, actually, we are going to see that is no doubt sepsis. Okay? So, a bit of epidemiology so we can understand what we are talking about. This is a recent review analyzing incidence and mortality due to sepsis worldwide. And authors state that sepsis accounts for 1 in 5 deaths globally and is the most common cause of in-hospital death in the US. Okay? Highest incidence in young patients and the elderly as well. That's important. So, we can say that while advances in managing of this patient has resulted in improved survival, there is still a large portion of patients, particularly the elderly, who constantly have worse outcomes. We can see that the trend of septic shock is going up in these decades. So we are facing an emerging and important issue in our hospital, and we are not solving it in a good manner because the septic shock, for example, still has a very high mortality. 55% of patients with septic shock are going to die in hospital. Okay? So this topic is of great concern for internal medicine specialists. Why? Because the majority of septic patients are admitted in our wards, admitted in internal medicine wards. They are usually elderly patients affected by chronic pathologies on polypharmacotherapies. So they are our patients, you know. We have understood that sepsis is a very important issue for us. Speak about what is sepsis. Yeah, we need an infection, okay? Infection, we can define infection as the presence of serious criteria plus specific signs of infection. For example, a patient with fever, hypotension, and with short of breath, he could have a pneumonia. That's an infection. But this is not sepsis because we need a host response. A host response with a lot of different pathways activated, pro-inflammatory, anti-inflammatory pathways, hormonal pathways, metabolic, and this response is not really appropriate. So when we have an organ dysfunction or multiple organ dysfunctions due to an inappropriate host response, that is sepsis. Okay? So sepsis mortality is due to an immunological disorder where the causative pathogen is considered irrelevant once the deregulated immune response has begun. So, of course, we need an infection, but sepsis is a host problem, okay? You know very well that for the clinically defined sepsis, we need to fulfill the SOFA score. SOFA means sepsis-related organ failure assessment. That's obviously an assessment of multi-organ failures, lung, cardiovascular, neurological, liver, and kidney failure, and so on. And we have two, three key points on the management of sepsis. We should recognize septic patients as soon as possible, and we should start the appropriate therapy as soon as possible for the infection, but also for the organ dysfunction. And I want to just present very quickly this study that I think is a great study on this field, because authors first describe the different pathways that can be activated in a septic patient. We can have an excess of inflammatory response, and we can have early deaths because of that excess, but we can also have an effect on the inflammatory and excess of immune suppression, and this can lead to that as well, or lead to further infections, nosocomial infection, viral reactivation, and so on. So after that, several studies have been made trying to understand if we can look further within the sepsis process. And this very recent study tried to use a machine learning approach. And with the machine learning approach, authors determined that data could be clustered into 4 types of sepsis. 4 types. The most common type was called the alpha type, with patients that had the most normal laboratory values and lowest death rate. For example, the beta type consisted of older people who tended to have chronic illness and kidney problems. Gamma type with more inflammation, high fever, and breathing problems. And the delta type with more liver issues and worse outcome. So the researchers also studied that results from several clinical trials that accounting for the different types of sepsis could have affected the outcomes of this trial. So by seeing sepsis as several distinct conditions, so it's a plural, conditions with varying clinical characteristics, we can discover and test therapies precisely tailored to the different type of sepsis. And this is a statement that I really like. The next step is to do the same for sepsis that we have for cancer. So we are speaking of sepsis like we were 20, 30 years ago for cancer. And we are trying to find therapies that apply to the specific type of sepsis, plural one, sepsis. So remember, patients cannot be categorized in only 4 standardized types. Most of all, if we consider our heterogeneous population in our internal medicine patients, okay? So let's do a bit of more question time. If I show you this table with several clinical aspects like multi-system involvement, hyperinflammation, vascular involvement, multi-organ failure, death, do you think that this is the clinical spectrum of sepsis, pneumonia, pancreatitis, or COVID-19? So green for COVID, purple is green, so COVID, or blue is sepsis.
Blue, green, I would say.
Yeah. Well, actually, we will see later, but we can say that COVID-19 is a septic condition. So both the answers are right. And again, if I show you this table, hemodynamic support, ventilatory support, a sort of therapies for a condition, corticosteroids, immunotherapy, anticoagulant, antimicrobial therapy, do you think that that is together the optimal management of sepsis, pneumonia, pancreatitis, or COVID-19? Up, up, up.
All of them.
Many
All of
colors,
them. I agree, all of them. Yes, great. So, there are several studies and several ongoing studies that we can use for saying that COVID-19 is sepsis, okay? It's a sort of septic process. But we will look into this later if we have time. So keep that in mind. How can we manage sepsis nowadays? You know that just a few weeks ago, we have had these freshly baked guidelines, the Surviving Sepsis Campaign Guidelines 2021. And there are 60 pages of recommendation, but we can find in those recommendations a lot of we recommend against 14 times. There is insufficient evidence to make a recommendation, or we suggest against of doing something. 15 times we can find that sentence. What does it mean? That probably we are not there. There are still a lot of things that we have to understand. Probably we are starting to understand that several things that we have done in our past is not so good for treating sepsis, but we still exactly don't know what we have to do for septic patients. So, given the current plateau in treatment options for patients with sepsis, the identification of host factors may identify patients at higher risk for poorer outcomes and provide a clinical advantage to treat patients. And that's why today we are speaking about the microbiome, okay? Trying to find host factors that can affect the outcomes, that can affect or predict the outcome. So, again, it's up to you. What do you think is microbiota? A specific type of diet, the smallest microbe that lives with us, a set of bacteria or microorganisms of a particular size. Who goes for a diet?
Green.
No one? Yeah, O or B or D, or B or D. So basically, we are going to see it later. What do you think is dysbiosis or dysbiosis? Oh. It's a healthy microbiota community. It's a loss of diversity of the microbiota community. It's a relative amount of specific bacterial groups, or is it a distinctive composition of the gut microbiome? Okay.
Most Bs maybe. And
Most of B. And I'll go for B as well. We'll see it later. So last one, probiotics. Probiotics. They are microbes. They are dietary fiber or antibiotics for prophylactic therapy or proactive particles. What do you think? Blue, green, green, blue, green, blue. They are microbes. Well, prebiotics, they are different. Pro and pre, prebiotics. You think they are microbes, fiber, antibiotics, or particles? Particles? Dietary fiber? Green, green. They are fiber. We'll see. Okay, so a bit of definition because we need it. The human microbiome has been defined as the collective genome of millions of bacteria, viruses, and fungi as well that exists on every human host. And specifically, the human gastrointestinal tract contains trillions of bacteria. So that means that we can say that we are made of bacteria more than human cells. Can you believe it? So the human gut microbiota has a large variety of bacterial species. We are counting around 200 dominant species and 1,000 of non-dominant species, okay? And that, I think, is very important. So a healthy microbiota is characterized by richness and diversity. A healthy microbiota is not that one with just a good species of microbe. There are distinct numbers, distinct species in the community, and with a lot of diversity. So diversity is a measure of the richness of that community. While we can define the dysbiosis as a microbiota community associated with a disease state and with the loss of diversity. In the healthy microbiota, we have 4 phyla represent most of the microbiota members: the Bacteroidetes, Firmicutes, the Actinobacteria, and Proctobacteria. And this biosis can be interpreted as a relative change in the composition of an individual's commensal microbiota. So this biosis is a decrease in the microbiota variety. That's the point. A healthy microbiota has several direct and indirect mechanisms that contribute to protection against pathogens, the bad one. Specifically, commensal bacteria activate innate immune defenses in the mucosa, can produce host-derived metabolites, can deplete nutrients, or produce substances that are directly toxic to competing bacteria. These mechanisms altogether can induce a high level of resistance. When we treat a patient with antibiotics, antibiotics eliminates many commensal bacterial species from the gut lumen and reduces the antimicrobial defenses. So you see, it's a very complex system. We cannot just synthesize it in a few words. The microbiota influences the function of the immune system, including local barrier function at the site of colonization, T-cell differentiation, cytokine production, antibody production, phagocytosis. And the most abundant phyla that we have seen before in a healthy gut, Bacteroidetes and Firmicutes, for example, are the major producers of what we call short-chain fatty acids, SCFA, which can regulate gene expression of T cells as well alter the microbiocidal capabilities. So they work together with the epithelial layer that plays a critical role in separating luminal toxins, metabolites, and bacteria from the underlying tissue. A balanced gut microbiota is able to enhance the host immunity to both enteric and systemic pathogens, and that disturbance of this balance potentially leads to increased susceptibility of sepsis. But on the other hand, other studies have shown that the composition of the intestinal microbiota is severely affected by sepsis and its treatment. So we can say that gut microbiota and sepsis, they have a bidirectional relationship. Let's have a closer look on it. So the microbiome composition is associated with the susceptibility to sepsis. And identification of patients based on their microbiota profile can have a role in studying septic patients. I want to show this recent study that was carried out on hundreds of adults receiving hematopoietic cell transplant. And it showed that intestinal domination with the Proctobacteria was associated with 7-fold increased risk of subsequent gram-negative bloodstream infection. And yeah, probably it's too small, but we can see a peak relative abundance and concomitant bloodstream infection with the Enterobacteriaceae. And again, a retrospective cohort study on more than 10,000 patients found that the risk of readmission for severe sepsis is 700 higher following hospitalization for Clostridium difficile infection than after hospitalization for other infection causes. I'm saying that if a patient is hospitalized for a C. diff infection, can be readmitted within 90 days for an infectious issues much more than a patient that has been hospitalized for a non-infective cause, okay? So, again, This study recently showed that exposure to longer duration of antibiotics during hospitalization were associated with dose-dependent increases in the risk of subsequent sepsis. So basically, the more we treat patients with antibiotics, the more we can have subsequent infection issues after that. And we have several studies on, for example, gut microbiome feature associated with sepsis onset and outcomes. And I want to just have a quick question again. So what do you think main mechanism or the main mechanism of dysbiosis-related risk of sepsis? The selection for pathobionts, that means a bad pathogen, or an altered immune response, or a decreased production of products, good products, or all of the above? That's the easy one. When you see all of the above, it's always all of the above, you know. Okay, and that is correct, because actually when we have a disrupted microbiota, we can have several mechanisms that can lead to sepsis. We can have a growth of a pathobiont, we can have an altered immune response, we can have a decrease of the short-chain fatty acids that can lead to sepsis, and that can worsen the outcome of septic patient. So an altered microbiota is not only a risk factor for septic events, but it's also associated with poorer outcomes. In fact, I want to show a few studies. For example, an extreme imbalance in gut microbiota may be associated with prognosis in critical ill patients. And this is fascinating. The gut microbiome appears to impact delirium, the septic-related delirium, not only indirectly via inflammatory pathways, but also by bacterial translocation to the brains of septic patients with gut-derived bacteria. And again, we can have an effect on the acute kidney injury related to sepsis, or lung injuries related to sepsis. For example, in this study, patients with ARDS have significantly higher abundance of enteric bacteria in their lung microbiomes that do healthy controls. And one possible explanation for this is the gut-lymph theory. So we have translocation, and through the lymph pathways, microbes go to the lung. Okay, here authors found that intestinal domination of Enterococcus at admission in the ICU were associated with a 19% increased risk for death. So if you have a particular microbiota composition with abundance of, for example, Enterococcus, you can have a worsened outcome. So dysbiosis could potentially be used as a biomarker in septic patients to predict adverse outcomes. And sepsis worsens gut microbiota disruption. So we have a bilateral relationship. Microbiota can lead to worsened outcomes, but sepsis can lead to a disrupted microbiota, okay? Following the onset of sepsis, there is frequently a loss of anaerobes that typically dominate in healthy individuals. Look at this study. This is great. In this elegant work, it was clearly shown how the selective pressure of three factors, obesogenic diet, an antibiotic exposure, and a sterile surgical injury can converge on the microbiome, resulting in lethal sepsis without the introduction of an exogenous pathogen. So we have to keep in mind that there are several mechanisms that can affect the microbiota during sepsis. And I want to show that there are endogenous factors as well as external modulators. As for the external one, keep in mind antibiotics, but also the use of proton pump inhibitors, the use of parenteral feeding, sedatives, opioids that can affect the gastrointestinal mobility, and so on. So antibiotics are a major driver of sepsis-related microbiome alteration, but keep in mind also opioids parenteral nutrition, proton pump inhibitors, as well as intestinal dysmotility, shifts in intraluminal pH values, and so on. And you can see here, yeah, maybe it's too small, but you can see that how the variety of microbes within a microbiota can change and can be depleted after an antibiotic treatment. So we have seen basically a vicious cycle, okay, where the microbiome plays a central role in sepsis, predisposing a host to infection and contributing to the development of organ failure, but also we have seen that once sepsis is established, the combined effects of a stress state, artificial nutrition, exposure to antibiotics can lead to a progressive disruption of the microbiome. So we should try to interrupt this vicious cycle, and we are going to see if we have some tools for doing it. Again, starting from the recent guidelines. There are several things that we can say about that, but I want to point out and show you just one table, table 4, about the planned duration of empirical antimicrobial therapy in several trials of shortened versus longer duration of therapy according to clinical syndrome. Obviously, we should keep in mind that we have to focus on the infective source, the source of infection. We have to find the source of infection and remove it. But when we know the source of infection and when we have tried to remove it, then we can choose between a shorter or a longer duration of the antibiotic treatment, and we should know that the shorter one is not associated with different outcomes. Same outcomes, shorter duration. And probably this is the first microbiota targeted therapy, preventive therapy that we can apply. Choosing for a shorter duration of antibiotic, saving healthy microbes within the gut microbiota of our patients. This is an important lesson. The less is more lesson in medicine. It's always hard to remember and to apply. So, several strategies, apart from the antibiotic stewardship, can be applied to modulate the microbiota. And they can be categorized in 3 groups. First of all, I'm going to speak about the selective digestive tract decontamination. This recent meta-analysis of more than 40 trials involving more than 10,000 of participants reported that the combination of prophylactic antibiotics reduces respiratory tract infections and mortality. But the selective decontamination is usually only sporadically due to concern about promoting antibiotic resistance. So, anyway, there are a few studies that show that there is the same prevalence of colonization or infection in the intervention group treated with the selective decontamination compared to the control group without intervention. That means that the perceived risk of promoting antibiotic resistance seem unfounded, and we should keep in mind that we can use this strategy. So, do you know which one is a possible selective digestive tract treatment? Is it rifaximin, cyclosporin, caffeine, or ciprofloxacin? A lot of blue. I agree. Rifaximin is a non-absorbable antibiotic and has a limited anaerobicidal activity. So in order to reduce the burden of aerobic gram-negative bacteria, can be used as a preventive treatment. So let's go over with the second kind of strategy that we can apply, using probiotics, even if they are not at all recommended for prevention or treatment of any infection. Why? We have spoken about this. Because if you remember, a healthy microbiota is characterized by richness and diversity, while dysbiosis is characterized by the loss of diversity. So when we give probiotic, we usually give 1, 2, maximum 3 strains of microbes. This is not improving the richness of the microbiota, okay? So let's see this recent study where authors state that probiotics perturb rather than aid in microbiota recovery back to baseline after an antibiotic treatment in humans. So probably we should not use them? Well, anyway, we have several studies. For example, probiotics are not useful to reduce the infective complication of acute severe pancreatitis. But we had also positive results, like in this study. The administration of probiotics for infection prophylaxis was associated to a reduction in infections and pneumonia. So there is no white and black. On the other hand, a recent study showed that ICU patients receiving lactobacillus probiotic, so just 1 strain, had an increased risk of lactobacillus bacteremia. So we can also have side effects of giving probiotics. So probably a one-size-fits-all approach toward treating patients with probiotics is not only limited in efficacy, yet also potentially harmful. So probably this is a good treatment when we will be able to give several strains of good microbes, and most of all when we understand properly the disruption of the gut microbiota of that single patient. So every patient is different. So there's a third way to prevent infection, aiming the microbiota, and this is the fecal microbiota transplantation. We can transfer enormous amounts of bacteria, but also of other microorganisms and metabolites as well. And FMT may allow for robust reconstitution and so can impact sepsis much more than the other strategies. There are only few cases described that with successful use of the fecal transplantation to treat sepsis. Well, actually only 5 case reports. And we have to keep in mind that we also can have side effects of fecal transplantation. For example, a recent study reported on 2 cases of bacteremia caused by drug-resistant Escherichia coli that was transmitted through the fecal transplantation that led the FDA to issue a safety alert regarding the FMT. But obviously, we need for a donor stool screening. We cannot transplant stool from everyone, okay? We have to screen before. So, fecal transplantation seems useful for prevention as well, not only treatment. In this study, considering, and this is a meta-analysis, a review one, considering only studies with low or moderate risk of bias, an eradication rate quite high was described. But there are several open questions regarding the fecal transplantation. I mean, transmission of pathogen, in my opinion, is not a concern, because if we made a proper screening, we can avoid this concern. But we still don't know where, the exact dose that should be administered, the best route of administration. We could also have long-term safety issue. But most of all, we still don't know which are the best candidates for the fecal transplantation and what is the correct timing of fecal transplantation administration. So just a few words, because I work within a group that is known for studies regarding fecal transplantation, starting from fecal transplantation indicating for treating C. diff infection. This was one of the first studies that showed that fecal transplantation was more effective than vancomycin for treating recurrent infection of C. diff. And we have, obviously, in-hospital stool bank, and we built a donor program for fecal transplantation, so we are avoiding side effects due to the program. And we are exploring new indications for fecal transplantation, such as chemotherapy-induced microbiota disruption. So, in summary, we have different management options. We can fecal transplantation that serves to reconstitute the patient's microbiota with the microbiota of a healthy donor. We can use prebiotics that are products that the existing microbiota can utilize for beneficial purposes, such as introduction of dietary fiber to increase the short-chain fatty acids producing microbes. And we can have probiotics that are bacteria, good bacteria, for the existing microbiota in an effort to compete with the deleterious microbes. All of these treatments should be further investigated because there are several concerns about that, and further studies are obviously needed. So we have an overview of clinical trials that are currently investigating the role of microbiome in care of septic patients. At Gemelli Hospital, where I work, we have one of that. And now just a few words, very, very quick, for the relationship between microbiota and COVID-19. So there are several risk factors associated with SARS-CoV-2 infection that can cause the gut dysbiosis. Dysbiosis contributes to hyperinflammation by increasing the intestinal inflammation and decrease the anti-inflammation mechanism. And this can facilitate the form of severe SARS-CoV-2 infection, so the severe COVID-19. This is one of the most known articles on this topic, very recent, describing the association between the gut microbiota composition and the disease severity. And you can see that there is, well, you can see that there is a lot of dots, but these dots correspond to an associations between gut microbiota composition of in-hospital patients and plasma concentrations of inflammatory cytokines and blood inflammation markers. So, author states that patients with COVID-19 were depleted in gut bacteria with known immunomodulatory potential, such as the Prausnitzii and the Eubacterium rectale and several bifidobacterial species, and that the composition of the gut microbiota in patients with COVID-19 is concordant with disease severity. And these findings suggest that depletion of the immunomodulatory gut microorganism can contribute to severe COVID-19 disease. And we also know, this is a different study, that the SARS-CoV-2 infection is a risk factor for other infections or complicated infections. For example, there is a correlation between COVID-19 hospitalization and risk of bloodstream infection. Bloodstream infections that are especially due to gut-derived microbes and multi-resistant pathogens, like the Klebsiella pneumonia or Candida species. Can I go over? Okay. So, going to the conclusions. There are several gaps in the existing literature, several aspects that can be further investigated and that can be addressed for each mechanism of disruption of the microbiota and each mechanism of preventive or treating strategies that we can apply. I just want to conclude with a few take-home messages. Probably the development of a rapid microbiota test could enable risk assessment during sepsis, and an approach of identifying patients with the highest expected benefit of microbiota targeting treatment, as well as selection of certain host and disease-specific contexts will facilitate the use of future microbiota treatment. But I think that the most relevant concept to be remembered is that sepsis is not an homogeneous illness. We have different septic patients. We have different types of sepsis. So we need to identify host and disease-specific contexts, and that is why the study of our microbiota is so relevant. So that the only way to go is that of precision medicine. Thank you for your attention. If you have any questions, we are here. If you want to just keep in touch, write me.
Just trying to put the microphone. Hi. Oh.
Hi.
Steve Holt, Saha Kidney Care. Thank you very much for a lovely talk. You mentioned that short-chain fatty acids were important. Why not bypass the microbiota, just give short-chain fatty acids?
Thank you for your question. Well, actually, this is just one of the several aspects that we still don't know. We have two studies where basically authors try to directly administer short-chain fatty acids with good effects. One of these is on acute kidney injury related to sepsis. So I can say, why not? We should try. We should try. We can make a trial on it, several trials. That's a good point. Thank you.
Khadija, thank you for a fascinating talk. I was just wondering, do we have any studies on the use of the prebiotics and microbiota in the management of Clostridium difficile colitis?
Sorry, can you say that again?
So do we have any studies on the use of probiotics in C. diff colitis?
Yes. Thank you for your question. Yeah, we have a lot of studies for using probiotics for preventing a recurrence or preventing the first episode in a patient with higher risk. You know that there are several risks in hospitalized patients like PPI use, antibiotics, elderly patients, and so on. Well, they have different outcomes. The main problem with studying probiotics is that we have a population that is too heterogeneous, okay? So probably this affects the outcomes when we study probiotics. But they're not conclusive. So we should keep on with studying probiotics, and I really would suggest to use different and simultaneous strains of probiotics for trying to improve the richness of the microbiota itself. Because when we use only one strain, even if that strain is known as for the good capabilities, that usually is not so useful. Thank you.
I have a question, Alberto.
Thank you for your attention. Thank you for being here. If you do not have any further question, we can conclude.
Thank you very much to all of you and for your assistance.
Okay.